All right, welcome. In this training explainer for surgical assistants, we're going to tackle D for disability. This is a super important part of the ATLS primary survey, and it's all about that initial neurological assessment and management.
So, in any trauma situation, we have to start with one fundamental truth. The initial impact, that primary injury, well, it's done. It's in the past. There's nothing we can do to turn back the clock on that.
Our whole mission, from the second that patient comes through the door, is to prevent what could happen next, the secondary injury. So this explainer is going to walk you through the key steps of the neurological assessment, all designed to protect the brain and spinal cord from any more harm.
Okay, let's dive right into it. The disability assessment is meant to be a really quick but absolutely vital check that we do during the primary survey. Think of it as a rapid snapshot of the patient's neurological function.
The goal here is pretty simple, and there are two parts to it. First, we have to establish a baseline. What is this patient's level of consciousness right now? And second, we're looking for any immediate, life-threatening neurological problems that we have to jump on this very second.
So how do we do this quickly and, effectively? We lean on two of the most powerful tools we have in our initial assessment, the Glasgow Coma Scale and a good look at the patient's pupils.
And here it is, the Glasgow Coma Scale, or GCS. You really have to know this inside and out. It's basically the universal language for assessing a patient's level of consciousness. It takes something complex and boils it down into three key responses.
First thing we check is eye-opening. This ranges from a 4, meaning their eyes are open on their own, all the way down to a 1, where there's no response at all, not even to pain. It's our first big clue about their level of arousal.
Next up, we listen. What's their verbal response like? Can they tell you their name? Do they know where they are? That gets a 5. Or are they just making confused sounds? Or maybe no sound at all? This tells us a ton about their higher brain function and how they're processing everything.
And finally, we have the motor response. Now listen up, because this one is the most important component for predicting how a patient's going to do. It goes from a 6 for obeying your commands down to a 1 for no movement. And remember, we always record the best motor response we see.
Now, right alongside the GCS, you've got to do a quick check of the pupils. It's super fast. We're looking at three things. Their size, are they equal, symmetrical, and how do they react when you shine a light on them? If you see something off here, it can be an immediate red flag that there's pressure building up inside the brain.
Okay, so we've taken a quick look at the brain. Now let's move down to the spine. While the final diagnosis is going to be complex, our job in this primary survey is to help the team decide if a serious cervical spine injury is likely.
For patients who are awake and stable, we can often avoid blasting them with unnecessary radiation by using what we call clinical decision tools. These are basically validated checklists that help the team safely rule out a major injury without needing to rush off for a CT scan.
And one of the most common tools you'll see is Nexus. It's pretty straightforward. If a reliable patient has no new neuroproblems, isn't intoxicated, doesn't have other major distracting injuries, is totally alert, and has no tenderness right down the middle of their spine, the team can probably clear their C-spine without any imaging.
But for the patients who do get that CT scan, we have to look for alignment. The radiologist is going to trace these 4 distinct lines along the spine. They need to form a nice, smooth, continuous curve. Any break or sharp angle in those lines, that's a huge sign of a potential fracture or some serious instability.
So let's bring it all together. After we do this initial check, our entire focus has to shift to one thing, and one thing only: preventing the terrible effects of a secondary injury to the brain and spinal cord.
And honestly, this slide says it all. The primary injury, that crash, that fall, it's happened. It's over. But the secondary injury, the damage that happens at a cellular level right there in the hospital, well, that's caused by a lack of oxygen or blood flow. And that part is preventable.
These are the two mortal enemies of any injured brain tissue: hypoxia and hypotension. They will starve the brain and spinal cord of everything they need to survive, and they can turn a recoverable injury into a permanent one. We have to be aggressive about finding and fixing them.
So, what does this all mean for you? As a surgical assistant on that trauma team, you play a huge role in this fight against secondary injury.
Your role is to be the team's eyes and ears. You have to perform spot-on assessments, understand the why behind clearing the C-spine, and always be thinking ahead about the need for resuscitation. But the most important thing, you have to constantly reassess the patient and communicate any change,
I don't care how small it seems, immediately.
So I'll leave you with this. Your patient's GCS drops from a 13 to a 10. That's not just a number changing on a chart. That's a fire alarm going off. It's a critical sign that something is getting worse, and it means the whole team has to act right now. Being the person who spots that change and speaks up, well, that can make all the difference in the world.